Good morning, everyone. We have a wonderful speaker this morning, Mr. Russ Nassoff. I'm going to read a short bio and then introduce him to the stage. Russ Nassoff is an attorney who has been involved in the fields of health risk consulting and clinician education for over 10 years, concentrating his work in the areas of infection prevention and risk liability minimization for vascular access issues. He has presented hundreds of seminars and webinars to legal, insurance, loss control, healthcare, and risk management groups throughout the United States, Canada, Europe, and Asia. While Mr. Nassoff has been involved as a consulting and testifying expert on several infectious outbreak events, his passion is focused on managing risk and liability for catheter-associated complications. He is the first non-clinician elected to the AVA Board of Directors and has also served as a reviewer on the 2016 INS standards. Mr. Nassoff received his Juris Doctorate and undergraduate degrees from Emory University in Atlanta. Please welcome to the stage Russ Nassoff.
Thank you. Good morning. It's very, very nice to be here. By the way, for the men in the room, the restroom in the back is locked. So if anybody has to run out, it's probably not a good thing to do. It's really an honor to be here. I'm just going to tell you, I tell many stories. As a lawyer, that's what we learn to do. And I will tell you that I had a funny story happen just yesterday. As I usually do at my house. I was packing, getting ready to leave, and my daughter, who's home from spring break, sees my suitcase. And she says to me, Dad, where are you going? And she knows I present all the time, and nothing really gets her very excited. I said, well, actually, I'm going to San Diego. Well, I live in Arizona, and San Diego to Arizona is like nirvana. It's like going to Mecca. So my daughter goes to me, you're going to San Diego? She goes, do you know it's 85 degrees there? I said, yeah. She goes, do you think anybody's going to want to listen to some boring lawyer talk about the Affordable Care Act when it's 85 degrees there? And before I even get a chance to respond, she's out the door. She says, good luck with that. So, and then on top of that, 2 days before, or 3 days, Renee calls me and says, oh, and by the way, my supervisor, Chuck, who's in this room, he's a little freaked out that you have 60 slides to go through on the Affordable Care Act. And so I'm beginning to worry, oh my gosh, 60 slides, boring lawyer, Affordable Care Act, San Diego, this may be a freaking disaster. But it won't be, because I'm a very different kind of speaker. As a lawyer, I am not qualified to mention your product. I may think that it's the best product in the world, and actually you have a great product. But I'm not qualified. I'm not a VABC. I'm not a CRNI. I'm not any one of those myriad of alphabet soups that many clinicians have after their names to recommend your product. But what I can do, and what I will do, is explain to you the importance of why your product and other products like it that are evidence-based are of critical importance to vascular clinicians today because of this Affordable Care Act. It is more important than ever that clinicians use evidence-based products. It's important because the goals of the Affordable Care Act, and as I see it really, there are only two of them. There's improving patient outcomes and there's reducing costs. And the two of them may seem to be conflicting goals. But regardless of whether you think they're conflicting goals or not, it's critical that you use evidence-based product to meet the goals of the Affordable Care Act. And so what I'm going to be doing today is not advocating a product, because I can't, but advocating how to position a product as best practice, as evidence-based, and as the products that must be used in order to meet the requirements and goals of this act. And so what we're going to be covering, essentially, is we're going to start with the business of medicine and how, unfortunately, today, clinicians can't only be clinicians. They also need to be business people. We're going to go into the background of why and how this happened, the solution to why and how this happened, and how we can go about trying to meet these goals. And then I'm going to cover small aspects of the Affordable Care Act and the problems with the Act, because there are many, many problems with the Act. And then why, as vascular clinicians, should you even care about this Act? Why is this important? And then I'm going to go over the legal stuff, the importance of product selection, and liability minimization. And by the way, Chuck, there are 60 slides, but I will tell you that really only 5 of them are of any value. So when we get to those 5, those of you who are kind of gazing out the window at beautiful San Diego, I'll let you know which 5 so that you can pretend like you're paying attention and really get it. So today, unfortunately, we have business driving clinical practice. That's the way it is. And that's the way it will probably be for the very foreseeable future. And so it's very important that clinicians also become business people. And this isn't to a huge extent, but every year it's to a greater and greater extent. So it's very, very important that you understand the business aspects and why they're important. Because as vascular clinicians, unfortunately, there's going to be increased scrutiny on everything that you do, on your products, on your practice, because the dollars, the bottom line, are going to be depending more and more on you. And as I mentioned earlier, we've got 2 competing goals here. We've got do no harm, or patient improvement, and we've got reducing costs or making money. And who better to talk to you about making money than a lawyer, right? Usually, we only bring the bad news, which is why a lot of times I'm the only lawyer at these clinical conferences, and I try and explain to clinicians how really lawyers and clinicians aren't so different. We're always, or all too often, never invited to lunch. Usually when I'm working at the hospital, I'm always sitting alone, and the reason for that is no clinician wants to walk by me because they're always afraid I'm seeing something that they're not. I'm always invited after the adverse event has already occurred. Never a good idea, usually. And this is how I feel at the end of the day, probably very much like many of you feel at the end of the day. But the solution to all of this, see, Chuck, I've already gone through 10 slides. Look at that. The solution to this is we really need to work together. Clinicians, the C-suite, lawyers, we need to work together because these 2 competing goals of improving outcomes and reducing costs are actually attainable. And when you look at the goals of what the C-suite is looking for, what hospitals are looking at in the United States, and I've underlined the important things, we've had a real switch. And this switch has come from the fact that we're no longer looking at a process that is fee for service. We're looking at a process that is pay for performance. How well are you performing? You shouldn't go into the hospital and get sicker and get paid for it. That's the whole idea. So we want to look at things like patient satisfaction, patient safety. We want to look at the government mandates that are now mandating this. We want to look at healthcare reform implementation, the ACA, and we want to look at the financial challenges around that. And that's what the CEOs are looking at. And where did this come from? It's very interesting. In the 1960s in Scandinavia, they had a horrible incidence of MRSA. These are countries that we think of as being pristine, clear, clean, healthy. Norway, Denmark, Sweden, the Netherlands. They had astronomical rates of MRSA. We're talking 30, 40%. And all of a sudden, what they started to do was institute a number of very, very good interventions, bundles, cohorting patients, active surveillance cultures, all of these things that we know can reduce infection rates. And they got the infection rates down to ridiculously low numbers. And I think even in the Netherlands today, I think the MRSA rate is something like 0.2%. Well, this was really interesting. And Dr. Peter Pronovost, a physician at Johns Hopkins, who I know, became aware of what was going on in Scandinavia. This is already 20, 30 years later, and starts to think, you know, if they could prevent an infection like this in Scandinavia, why can't we start preventing things like this in the United States? And I'm going to focus on CLABSI, central bloodstream infections, because they're very important, they're very costly, and they're of great harm to patients. So Peter, in conjunction with a bunch of other people, came up with a great CLABSI bundle, a series of interventions which he felt were going to reduce the central line bloodstream rate. And in the state of Michigan, he started a study, which we call the Keystone Study, where he was able to get the infection rate for central line infections down to 0 across 105 ICUs for 5 years. An absolutely astounding accomplishment. The guy even jokes about it. He tells me, yeah, I got a genius award for this. Well, I don't know whether he's a genius or not. But what happened from Peter's little Keystone Study was that everyone in the United States started talking about prevention. Prevention became the watchword. Everyone in healthcare wanted to talk about prevention. And what happened after that? We all started focusing on what? 0. 0. Everything became 0. APIC was getting to 0. We want 0 infections. We want 0 this. We want 0 this and that. And why? Because Pronovost got his infection rate to 0. Well, as a lawyer, I can tell you something. 0 is a very, very dangerous number in healthcare. Because unfortunately in healthcare, stuff happens. And many times 0 is not attainable. Many infections are in and of themselves not preventable. And what happens when I go into court, if I'm representing a small little hospital in Iowa, let's say, who doesn't even have an IP on staff, but they happen to have a CLABSI, right? Maybe through no fault of anyone that we can figure out. And the lawyer on the other side says to me, hey, Nassoff, aren't you aware of Pronovost's study where he managed to get the infection rate down to 0 for 5 years across 105 ICUs? Your guys over there in Iowa must be negligent. They had a CLABSI. That should never have happened. Well, unfortunately, it's a very, very hard argument to combat. And my argument with Peter is not that he didn't do a great thing, but did he set the bar too low? Did he set the bar so low that all of a sudden everyone is focused on 0? And I can tell you something else. Last week I was presenting in Pittsburgh. I forget the name of the woman who was presenting, but she also had an outstanding story where she happened to get the CLABSI rate in her hospital down to 0 for a couple of years. But then what happened is they had a blip. They had a CLABSI. So her graph kind of looked like this, right? That blip is deadly in a lawsuit. Why? Because she was able to do it for 3 years. That blip meant that something must have happened. Someone must have screwed up somewhere, because if you were able to do it for 3 years and something happened and then you were able to do it again, clearly there must have been an error somewhere. So what we would like to see, rather, from a defense standpoint, is continuous improvement rather than hitting your goals on a sporadic basis. Because if you do it once and then you don't do it again, you don't look as good. In addition to that, think of this. When nothing was preventable, there was no liability. Now, what happens every year? More and more and more and more is preventable. And why? Guess what? The insurance companies don't want to pay for anything that's preventable. So if I fall off the stage, and I'm not allowed to move off the stage, I was told, but if I fell off the stage, that falls are questionably preventable, right? But falls are now included by the insurance company as something that we shouldn't pay for if they happen. So in addition to the insurance companies now pushing this every year to say more and more shouldn't be preventable, we've got the regulators now who want to say, well, 0 is the number. So if something happens, we want to know about it. So you're going to have to start reporting everything. And guess who's following suit? All the plaintiffs' lawyers who are smelling all this great money out there. Why? Because if something is preventable and it happens, there's got to be liability somewhere. And that is what's driving all of this regulation today. And unfortunately, who's making the decisions? Not you clinicians who are out on the floor every day doing the hardest job on earth, in my opinion, with respect to the alarms and caring for patients and complexities, and we'll go into some of these. But the regulators in Washington who don't understand the first thing about healthcare other than they hear the number 0, they see an issue, and they think it shouldn't have happened, and there must be liability, there must be fault, and we shouldn't be paying for this. And where did this all start from after Pronovost? Well, in 2001, the National Quality Forum came up with a list of 29 events. Actually, they didn't come up with 29. It has become 29. And we call them never events, right? Now, these are really never events. These are events that should never, ever happen in healthcare. Electrocution, wrong site surgery, losing a patient. These are horrendous things. But what happened again is it wasn't the healthcare people who were looking at this. It was everyone else who heard the word never event, and they started mushing all this other stuff that weren't really never events, but they started calling things that shouldn't happen never events. Now, as a lawyer, never means never. So what happens is people start calling things like infections never events. Well, they aren't never events. They aren't on the never events list. There isn't one infection that I know of on the never events list. But people started calling these things never events, implying liability. What we prefer to call them is actually serious preventable events. And then jump ahead 7 years later to the Deficit Reduction Act. This is the beginning of all the legislation that we see today. This is the beginning of hospitals being responsible for hospital-acquired conditions. And what essentially the Deficit Reduction Act said very, very simply is, if you went into the hospital with A and you came out with B and it was reasonably preventable, then you wouldn't be paid the differential between A and B because it was preventable. When the sole reason for the differential was preventable through adherence to, again, here we got the first use of evidence-based guidelines, we're not going to pay you. And what did they include? First time we see this, vascular catheter-associated infections. And they didn't bother to specify, are we talking about a midline? Are we talking about a peripheral line? Are we talking about a central line? What are we talking about? We don't care. It's a vascular catheter-associated infection. We're not going to pay you. So what happened because of this is the present on admission conditions became very important, because if we weren't going to pay you for what you came out with, we sure as heck better know what you came in with, all right? Then we get to the Affordable Care Act. Now, this is already an old slide. There are 18 million now newly insured, not 16.4. And there are some good things about the ACA. Clearly, the number of insured is declining, but the whole basis of the ACA is it shouldn't be pay for service anymore. It should be pay for performance. If we do a good job, you should get paid. The goal being that 30% of the payments are going to come from other sources other than fees. And there are 4 of these issues under the ACA that I want to talk about: the Readmissions Reduction Program, hospital-acquired conditions, value-based purchasing, and the in-quality reporting system. And all of these 4 programs are intended to work together to meet the goals of the ACA. Again, improving outcomes, reducing costs, and increasing patient satisfaction. Okay, Chuck. First important slide, okay? This is one you need to pay attention. Why the heck should we as vascular clinicians give a damn about the ACA? What does it have to do with us? Number 1, it focuses on improving patient outcomes. Number 2, these outcomes are going to result from a reduction in vascular catheter-related events. As you're going to see, most of the ACA is focused on vascular catheter issues, and the reduction in those can come about from selecting the right product for the right patient at the right time. And guess what? If you don't, you're going to be dinged for it. You're going to be penalized for it. So the bottom line is, we're looking at you, vascular clinicians. If you screw up, your head may roll. Your C-suite's going to be looking at you because you know what? You're going to be losing money. And nobody wants to lose money today. Everyone wants to improve care, no question about it. But as I mentioned from the beginning, the business of medicine is driving clinical practice today. So what do these programs say? And this is going to be very brief. I'm not going to go into all this detail about these silly programs. But readmissions, okay? 3% penalty, and this doesn't have to do so much with vascular, but it does have to do with other issues. So essentially, hospitals that have excess readmissions on things like acute myocardial infarctions, pulmonary issues, total knee and hips, and there's more to be added later. If you have readmissions over the expected readmissions for these three issues, you can be penalized up to 3%. Now, let me tell you the problems with this. Number one, since we're in the state of California, I can tell you over 50% of the hospitals in California got penalized last year for readmissions. You get penalized for this even if your readmissions are decreasing, if you're still over what the expected rate is. So even if your hospital's improving, guess what? You're still going to get dinged for it. And the other ridiculous thing about this is, let's say I go in for a total knee and hip, right? But 2 weeks later, I break my thumb and I go into the hospital. That's a readmission. So does that really make sense? Not really. In addition to that, what we're finding is that the readmissions are not really the result so much of poor care, but they're the result of demographics. If you've got a population that doesn't speak English and doesn't understand the discharge instructions, you think you're going to get more readmissions? I think so. It's also the result of poor communication between the doctors and the patients and the doctors and the doctors. And in addition to that, many of these discharges are happening prematurely because hospitals want to get that turn. They want to get rid of patients quicker. So just because you've got a higher readmissions rate doesn't necessarily mean your care is any worse. The next one is hospital-acquired conditions. This is where we start getting into the vascular issues and the vascular penalties, okay? You don't want to be at the top of this list. The top 25 is a bad place to be with respect to this issue because that's where the penalties arise. And they've done this because 1 in 25 people in this country that goes into a hospital is going to come down with an HAI. In 2007, there was something like 200,000 plus HAIs in this country. And what do they list on this HAI list? But central venous catheter bloodstream infections. At least here, it's specified as a central infection. What is this composed of? Well, there are two domains. The first domain is the AHRQ domain, and you see there central venous catheter-related bloodstream infections, and it's weighted 25%. The second one is the CDC measure, where you see CLABSI, again, central line infections, and it's weighted 75%. So this is the only issue that's on both domains, which means if you've got a vascular event and it's an HAC, you're going to be dinged doubly for this issue. So again, the focus on vascular-related events under the Affordable Care Act. The third one, value-based purchasing. This is kind of a very deceptive title because it doesn't mean if you buy more, you're going to get more value. The way value-based purchasing works is this. It's meant to be kind of budget neutral for CMS. And what that means is, in the beginning, as a hospital, if I give this guy up front here $5, which is my 2% that I've got to pay up front, if I do well, I may get that $5 back. If I do poorly, I'm not going to get that $5 back. And if I do really well, I may get $10 back. So you can either win or you can lose with value-based purchasing. And what is this based on? It's based on a total performance score that is either improvement or achievement or both. So improvement is how well are you doing at your own facility from what your baseline was. And achievement is how well are you doing in comparison to all other hospitals? And that's how you get your total performance score. And what's interesting with the total performance score is that you see in that 2013, they weighted clinical process, again, fee for service, very, very highly. But what's happening is there's a shift onto all of these pay-for-performance type of issues. So they're weighting things like patient satisfaction, outcomes, safety, and efficiency very, very highly, much more highly than clinical process. So again, the emphasis is shifting as far as how well you're doing with respect to patient care. And what does this mean in total? It means that up to 6% can be deducted from your bottom line as far as how well you're doing on these issues. And 6% can be a heck of a lot of money. And in addition, this doesn't take away from anything that you're losing also under the Deficit Reduction Act that I mentioned previously. And what does this mean in terms of dollars? A lot. A lot. So here you can see the averages. So for hospital-acquired conditions alone, the average penalty was $541,000. Guess what? You ain't getting your bonus this year. You start having deductions like this, and guess who it's going to hit? It's going to hit the clinicians. And if you've got bad vascular data, if they're hitting you because you've got CLABSIs, you've got CRBSIs, you've got infections related to catheter issues, that's where the scrutiny is going to hit. And if you're really bad, that could turn into $8.5 million a year, which could put your hospital out of business. That's the importance of this act. And that's why vascular clinicians need to be aware of the importance of what's going on with this act. In addition to that, there are incentives under the act. There's incentives for something called in-quality patient reporting, and that's how well do you report. So in other words, some knucklehead who knows nothing about healthcare is supposed to be able to get on a website like Hospital Compare and be able to compare St. Mary's to St. Joseph's just by looking at the data. In theory, this sounds like a very good idea. In practice, again, not so good. And if you look at the ratings, the Billings Clinic in Billings, Montana, last year was rated higher than the Cleveland Clinic. Okay? So what they're finding with these ratings is teaching hospitals, hospitals with more complex patient populations, hospitals that do more complex procedures, guess what? They're not getting such good ratings, but it has nothing to do with the quality of the service that they're providing. Yet this is a first attempt to try and compare Hospital A to Hospital B. And they're using these NHSN definitions of infections in order for you to report. It's putting a big burden on clinicians, and in addition to that, as I'll go into in a minute, the definitions are virtually impossible to even work with. So the data that's coming out, we don't really know how good the data is. Lastly, on the ACA, just very briefly, I give a whole lecture on this, is the high-tech portion of this act, which is the electronic medical records component, whereby you need to put in electronic medical records because otherwise you're not even able to gather the data that the ACA requires. And only 22% in the latest poll that was taken think that electronic medical records are actually helpful. But unfortunately, they're here to stay. So the goals, just to sum up, we've got the program, we've got the process, and we've got the goal. The program, reducing readmission, non-payment for healthcare-associated conditions, and value-based purchasing. We've got the process, as I mentioned before, how we're going to be doing this, and we've got the goals. Reducing readmissions, reducing HAIs, improving satisfaction and patient outcomes, and look at the last one, using evidence-based medicine, which I'm going to get into in a minute and why that is so important. And guess what? Guess who's made all of these brilliant decisions? Non-clinicians. Non-clinicians who virtually have no idea how the healthcare system works. Non-clinicians who probably haven't been on a hospital floor in 20 years, but they're making the decisions. And this cartoon is great because it kind of sums up some of the silliness that's gone on with respect to some of these regulations. But that is an aside because they're here to stay. So just to give you an example, prevention, right? We talked about prevention, prevention of infections, prevention of central line infections. Are these preventable HAI sources? Overpopulation, multi-drug resistance, visitor hygiene, patients' own endogenous conditions, physical proximity of patients, increasingly invasive procedures, use of antibiotics, and unfortunately today, there's usually so much going on in a hospital that it's almost impossible most times to pinpoint the source of an infection. There are so many vectors of potential infection from the ties, from the shirt sleeves, on down, that if you ever find the source of an infection, it's very, very unusual. So many times, unfortunately, we can find that precise link for the source. We can't link the environmental source with the transmission event. And many times, all we can do is try various interruptions to see if the outbreak stops. I always used to have this pet peeve. I'd go to the gym every day, and I'd see these physicians getting into their scrubs in this locker room that I know is filled with MRSA and God only knows what else. And they walk right from the gym into the hospital. And I'm thinking to myself, don't you guys realize you're bringing in all kinds of contamination into this hospital? And I went to one of the gurus that I work with, and I asked her, I said, isn't this a horrible thing? And she said, in theory, it probably is a horrible thing. The problem is, it's so hard, if you've got an infection, to pinpoint the exact source of that infection, that sometimes all we can do is try various interventions and see if the infections go away. So it's a very, very difficult problem. In addition to that, has anybody looked at the NHSN definitions? I mean, this is what lawyers do. I will tell you something very interesting. If you go on any of these healthcare forums, APIC's got a forum, Ashram's got a forum, everybody's got a forum, where the nurses go about and they ask questions. And most of their questions have to do with, is this a eclampsia? Is this a CAUTI? Why? Because the definitions are so complicated, nobody knows what the heck they've got. The definition for a catheter-associated urinary tract infection from APIC is now 6 pages long. How can a nurse who's bombarded with alarms, with patient emergencies, with learning how to use electronic medical records, and then have to figure out whether she's actually got a CAUTI or not, or a eclampsia, because she's got a report on that, and her bonus may be depending upon it, and the hospital's financial condition may be dependent upon it, and you've got to use these definitions that have so much information that I can tell you all they have done with these definitions is made this a plaintiff's dream. Because any plaintiff's attorney can find problems with these definitions, but unfortunately, these are the definitions that you've got to use. And I just, sometimes I read, I don't know if I'm going to read one of these or not. I think I'll do that in a minute. Even the simple thing of present on admission, right? You would think that would be easy. 2 days before, 2 days after, should be very, very easy to figure out if you've got an HAI. But even present on admission, look at the problems with just present on admission. Many infections are asymptomatic after onset for some time. Colonization and inflammation, they're not infections. Extensions of infections, which are present on admission, obviously they wouldn't be HAIs unless there's a change of pathogens, but this isn't applicable to things like surgical site infections and ventilator-associated events. What about device removal and reinsertion? And I'm just going to read this to you, okay? Because I had a case to figure out when the device day started. So I figured, oh, no problem. We'll just look at the definition. This is the NHSN new definition. Device count starts anew only if the patient is without the device for 1 full calendar day, which is not equivalent to 24 hours. Okay, so already, when I went to school, a day was 24 hours, but maybe not anymore. I'm already confused. If the device is reinserted prior to an entire calendar day having passed without the device count will continue for HAI purposes. Can you figure that out? I mean, how can a nurse be expected when they've got 25 other things going on to figure out what definitions like that mean? There's no consensus for things like when do you change catheters out. Eclampsias, for example. You know, the infection can be coming from my friend Shelley DeVries's peripheral lines. But if you've got a central line in, they're going to call it eclampsia. But is it eclampsia? Maybe not. And what about the peripheral line rates? Does anyone other than Shelley care about peripheral lines? And Shelley obviously is a friend of mine. So Shelley and I were talking last week. We were both presenting in Pittsburgh. And Shelley comes up every time. I always try and listen to Shelley, because whenever she talks, I get a couple little tidbits. So Shelley mentions this thing last week in Pittsburgh. She says to me, do you know that 57% of nurses aren't trained to insert peripheral lines? And I said to her, you know, Shelley, that's remarkable, because up to 50% of these peripheral lines fail. I said, do you think that has anything to do with the fact that these nurses aren't trained how to insert the darn lines? But most patients get a peripheral line, and nobody's looking at them. All right? Nobody's looking at them. Why? Because the infection incidence is low. Oh, it's only 2.2%. Well, guess what, guys? 2.2% of 300 million, that's an awful big number. And you know what? The bugs don't care what line they're going up. They don't care if it's a central line, if it's a midline, if it's a port. They're going to go in there and they're going to cause an infection. I had a colonoscopy, my first one, a couple of months ago. They're inserting that catheter, and let me tell you, all my thoughts are thinking about what bugs are going up that line. So that's another thing you need to be aware of is, you know what, peripheral lines are problems, and we need to, my new slogan is, we need to respect the peripheral line, because in my opinion, I don't care where my infection comes from, I don't want it. So, Chuck, second most important slide. Vascular clinicians. Focus of the ACA on vascular issues without regard to the type or location of catheter. Peripheral line, central line, we don't care. Penalties and incentives for you vascular related events and you vascular clinicians. Increased scrutiny on reporting, adverse event occurrence, improvement, patient satisfaction and outcome, and product selection becoming critical. It's practice, product, and people. And we're going to talk about products. And guess what? In addition to all this, and all the pressure that you're now under with these crappy definitions, with all of this these problems with respect to reporting, you've got more patients, you don't have more staff, you have more responsibility, they ain't paying you any more money, you've got more documentation, you've got no more time, and guess what? There's also this increased liability now which is creeping up even for clinicians, and I'll go into that in a minute. You can always be sued. First thing I tell clinicians all the time is, do you have your own insurance? You've got to have your own insurance because it's the only thing that can protect you. And if you're giving out free nursing input, like, hey, Becky, do you think my son has an infection? Guess what? You can get sued for that. If you're on a plane and they say, hey, any nurses on the plane? We need your help. And you're going to think, I'm the Good Samaritan. I got to go help, right? Well, you are protected, but you can still be sued. And sometimes, even if you're protected by your hospital, your issues, your goals are not going to align with the goals of your hospital. This is the cheapest insurance you can get. It's $200 a year, and everybody should have it. And the big news is that nurses are stressed out. Ha! Guess what? The Nursing Times, they have the answer to all of this, because what the Nursing Times says is, to combat work-related stress, hospitals are offering knitting, creative writing, and dance to help nurses relax and prevent burnout. Well, I don't know. I don't know if it works or not, but the Nursing Times says it's a good idea. Now we get to the legal stuff. And I find all too often clinicians are bantering around these terms like standard of care, evidence-based practice, blah, blah, blah. They all have legal implications. Nurses don't have a clue what the legal implications of these things are, yet they're using them all the time. So this is what I'm going to go into in the last part of this presentation. Medical malpractice is when a medical professional doesn't adhere to the standard of care required of them and negligence results in harm to the patient. Negligence, legal definition, there's a duty, there's a breach, there's a result, and there's a damage. Those are the things that need to be present for medical malpractice. What is the standard of care? The standard of care is the caution that a reasonable person in similar circumstances would exercise in providing care. Most important thing here is similar circumstances. You can make mistakes. You can be wrong. You can't be negligent. What I explain to people kind of as a good analogy is this. Technology is a real good example. The legal rule with technology is if it's readily available, if it's reasonably reliable, and if it won't harm the patient, you've got to use it. So if you're in a hospital, you're in a great medical center, and you have all the tools available to you, and you happen to, let's say, have an ultrasound machine on your floor, but nobody uses it, and you stick that patient 7 or 8 times because you can't get a line in, that's where negligence occurs, because you have the tools to use them and you don't use them appropriately. Had you not had the tools available, you'd probably be legally in a better position for defending yourself. The standard of care. Experts are always going to differ as to what constitutes the standard of care. Nursing has always been based on using some type of evidence, but the standard of care is rarely 100% evidence-based. But I can tell you, the important thing for you to understand is the more evidence-based practice and product you have behind you, the stronger the standard will be. In addition to that, the less likely it is that you're going to have any liability. And what is evidence-based practice? Essentially, it is integrating the best scientific and the best experiential evidence. So science and experience, that creates evidence-based practice, that creates evidence-based medicine. It's not going to prevent you from getting sued, but it should, again, we're trying to meet the goals of the ACA, improve the quality of care, and decrease your chances of litigation. How does product selection fit in with evidence-based medicine and evidence-based practice? Important slide number 3. Okay, using products that are evidence-based, proven and tested, should reduce adverse events and improve patient outcomes, a goal of the ACA, should reduce variation across the continuum of care. Always good to reduce variation, it improves outcomes. Should reduce medical malpractice. Why? As I mentioned before, because it will validate that you are meeting the standard of care or at least going in that direction, supported by industry standards, and is going to reduce costs and improve reimbursement under the ACA. So are products the only solution? They're not the only solution, but they are an important solution. And as I mentioned before, we also have practice and we also have people. The National Patient Safety Foundation. Hospitals should implement policies and practice aimed at reducing the risk of central line infections and surgical site infections that meet regulatory requirements and are aligned with evidence-based standards. The gold standard, CDC. What do we look at as lawyers when we've got a case? The first thing we go to, what does the CDC say about that? And I'm the first one to tell you that they're not always right about things, but they are still the gold standard. And what do they say? Use evidence-based recommendations for preventing intravascular catheter-related infections. And what are those 5 things? Education of healthcare professionals. Now, education, I can tell you as a lawyer, doesn't equal competency. Education might just be alphabet soup. It might mean that you have a ton of initials after your name. But education is important. You've got to prove that it's there. Use maximal sterile precautions. Use more than 5% chlorhexidine gluconate skin prep. Avoid routine replacement of catheters. We know now that we're doing this only when clinically indicated, according to the CDC, no more than every 72 to 96 hours. And if those 4 don't work, what do they say? Use a CHG impregnated sponge dressing. And this gets a category 1B. That's a recommendation that's pretty darn high. Strongly recommended. So I know if people are scrutinizing what I'm doing, if my reimbursement and the financial condition of my hospital and maybe even my bonus and my job security is on the line, and I'm going to be scrutinized for adverse events relating to catheter-associated infection, I sure as heck want to use something that's evidence-based. Product selection. What do we hear? 2 different things. We've always used this, or they've changed it again. I can tell you that the worst words I hear in healthcare is, this is the way we've always done it. Those are probably the most dangerous words in healthcare. Just a very short story. I was on an audit in Indiana with a nurse who was probably old enough to be my mother. She had more practice than probably anyone else I had ever been with. She's taken out the IV caps and she's putting them in her mouth, and she's talking to me with the IV cap in her mouth. And I'm thinking, this can't be good practice. But this is the way we've always done it. So this is what you need to combat when you're trying to get a product across. So if you're trying to make a change, and you're trying to introduce evidence-based practice because this is what they're going to need to do to meet the standard of care and comply with the ACA and make their money and improve patient outcomes, show me the data. The data is everything. For lawyers, I want to see the data because all products are not alike. They may look alike, they may act alike, but they're not all alike. So, Chuck, last important slide. Very, very important slide. The legal and clinical standards. If you don't get anything else from this presentation, get this slide. What do I look at? Again, I can't recommend BioPatch. I can't. It's not because I don't think it's a great product. I'm not qualified. But what do I look at when I'm trying to get a product, when I'm trying to think, is this the right product? Was the right product used? And when I have a patient who's been injured, I look at what's the clinical evidence for that product. Is it a level 1, randomized control trial, cohort study, or just somebody's vague idea? What do we got here as far as clinical evidence? Does it work? Number 2, what standards is it complying with? Remember the gold standard, CDC. That's what we look to first. There are other ones. I've certainly been involved with many of them. We want to look at them. What's the active ingredient and how much of it is there? And what's its delivery? That's what I want to know. And is it recommended? What's the duration and durability of the product? Does it last? Does it last as long as it was supposed to have lasted? What's the infection prevention capability? Does it prevent CLABSI? Does it prevent CRBSI? What is it supposed to prevent? And how about the design? Is it doing what it's supposed to do? If I've got a bandage on my arm and there's goop seeping out from my bandage, that's not a good bandage. I don't have to be a nurse to tell you that. If it's only covering half of my incision, guess what? That's not a good bandage. If I can't see what's going on behind it, that's not a good bandage. You don't need to be a freaking genius to understand things like that. Is it cleared indication? If it's cleared indication by FDA, what's it cleared for? How long has it been on the market? There have been a lot of products that are on the market for 3 weeks, but what's their success? What's their market share? And believe it or not, people don't read labels. I've got so many cases with clinicians who never bother to read the label. What does it do? How does it do it? How does it work? And does it meet best practice? Patient issues are very important, and I'll go into these in a second. Are the patients happy with the product? Do you rip off half their skin when you take the darn thing off? They're not going to be happy. And what about stability and securement? I can tell you that the bulk of the legal cases that we get with vascular issues have to do with improper securement and stability. Very, very important today. And how about paying for itself? Does the product pay for itself over time? And if you're a patient, what the heck do you want in you? Well, I can tell you what you want. You want the best product. You want the least intrusive product, the one that's going to cause the fewest adverse events, the least pain, be in there the shortest period of time, have a good product history, and not cost you an arm and a leg. That's what you want. So you try and marry those two up. And this is the very last slide and the last important one. Program summary. Remember, standard of care. The caution that a reasonable person in similar circumstances would exercise in providing care. That's you, the vascular clinician. What tools do you have available at your facility? And how are you going to meet that standard of care? How are you going to meet that standard of care is to practice evidence-based medicine, integrating science and experience. And Practicing evidence-based medicine is a goal of the Affordable Care Act. Why? Because you're going to improve patient outcomes. If you're using things that are evidence-based, the patients will do better. And if you're ever sued, I can tell you that's the strongest thing you can go in with. When I ask you, what did you do and why did you do it, which is always my question, you better have that answer for me, because you're going to reduce readmissions if you do, you're going to reduce HACs, hospital-acquired conditions, improve patient satisfaction, and improve the bottom line. And so, as I said to you in the beginning, I'm not a nurse, I'm not a clinician, I have none of those fancy initials after my name. But I can tell you what I do know. I know about the Affordable Care Act. I know that there is going to be increased risk and scrutiny for vascular clinicians as a result of this act, because a large amount of payments is based upon what you do and what you don't do. And product selection, and the importance of product selection, and the importance of evidence-based product selection has never, ever been more important. And if you screw up, guess what? The focus is going to be on you if patient outcomes don't improve and penalties are imposed. So it is now more important than ever to select the best product for each patient every time for all lines. Thank you.
Thank you so much, Russ. That was amazing presentation. If you have a minute or two, are there any burning questions? Just a couple of burning questions. So I got Krista and I got Sean.
I don't know if it's burning, but okay, so what is your opinion? You've got the CDC guidelines and you've got a recommendation of a chlorhexidine sponge dressing. From a litigation perspective, you know, they have the other chlorhexidine sponges, but the studies that were done to make the recommendation were done on BioPatch. Is there a gap there, or are they safe to say we use a chlorhexidine-containing sponge dressing per the CDC, so we are protected? Did that make sense, the way I phrased that?
Say it again. Just rephrase it.
Okay,
I think I know where you're going.
Okay, you've got the CDC guidelines that recommend a chlorhexidine sponge dressing. There are several on the market. They made the recommendation based on 4 studies, all which were BioPatch studies.
Right.
Is there any liability anywhere because people are using a different dressing, different design, different concentration, but it still is a CHG sponge dressing? Without the indication. You know what I'm saying? Can they hide behind that? Can the hospital and or the other companies kind of hide behind that because it is a chlorhexidine-containing sponge dressing?
Okay, so the simple answer to that, as a lawyer would give you, is yes and no. Or my second best answer, it depends, all right? And clearly, because the studies, and I have the data from Renee, because the studies were done using BioPatch, the strength of your evidence is much greater. And there are problems, as we know, with some of the competing products that were used. Either they don't release in a timely fashion, they don't release the same amount, they deteriorate over time. So I think that those are the things that you need to highlight if in fact questions are brought up to you. Is it better than using something else? On the other hand, yes, probably, but is it as good as using, you know, it's kind of like I like to compare it to cars. You know, would I rather have a Mercedes or a Chevrolet or an old junker? I'd rather have the Mercedes. And if the Mercedes is out there and the Mercedes is available, why not use the Mercedes? Why are you going to use anything less? And if you're talking about saving a couple of pennies, what I always bring up is the financial implications of having an issue because you're not using the best product. You may be being penny wise and pound foolish.
Okay. So one of the major obstacles that I have, and I'm sure everybody else does too, when we are talking with clinicians, is what you pour into the definition of evidence-based medicine. So I was hoping maybe, because you mentioned, you know, use the best science. So if you could define that a little bit, because clinicians, more often than not, when they're looking at other products, look at company-driven, internal, in vitro data and say that's evidence enough. So can you just talk to that a little bit?
Yeah, and company-driven data is always suspect, in my opinion. And, companies obviously have a vested interest in promoting their own product. So any data that you show that your own company data is always not going to be treated as well as something like an RCT. So I always look, we always look at level 1 recommendations. That's always the first thing. How many level 1 recommendations are there? Who's made those recommendations? And try and stack those up when you're confronting data that has been company driven only.
And just kind of a follow-up is, because you were talking about evidence-based medicine as best science plus experience.
Right.
A lot of people focus only on the positive and overlook the negative experience. How much does that play a role in liability if they overlook negative experience? For example, on the FDA mod database, if you take the first 25 complaints for Tegaderm CHG, the vast majority, I think I forget, it's like 21 out of the 25 ended up in some type of skin reaction, and 16 of the 25 ended up in catheter removal. Does that open up the door for liability? How much of an issue is that?
I'm trying to does it open up the door for liability with respect to
Ignoring the negative evidence.
for Tegaderm?
For example, yeah, so a hospital wants to switch from BioPatch to Tegaderm CHG, and they look at only internal data, which is the first part of my question, and then they ignore the negative experiential data that's documented at the FDA.
That's a good question. I mean, if there's an issue that comes up where a plaintiff does experience one of those negative effects which was brought up, that will clearly be brought up, in a trial or in a deposition, like, aren't you aware that there have been negative effects on this? But from a sales perspective, I think every product will have some negatives. I mean, there's always going to be some negatives. It's just a question of how they want to weight it. I don't really think it's all that important. What I would rather emphasize is the positive rather than the negative, because I haven't looked, but I'm sure there are some negative BioPatch experiences too. I mean, when I try and ask people, hey, do you use BioPatch? I've heard some reasons why people don't like it. Again, because these are only complaints and they're not really studies, they don't really have all that much weight. So, if there are documented articles about, hey, these are the negative implications of Tegaderm, this is our experience with Tegaderm, and it gets published, that's a different story than just looking up and saying, hey, there have been a couple of complaints about it. Not that it won't be brought up, but it will be given much less weight than a recognized study.
Yeah, so if a hospital switches from, say, the BioPatch to another product without an indication, and then they have an increase in their CLABSI rates, would that increase their liability?
Possibly. Possibly. Of course, there are a lot of factors that go into that. But again, remember my graph, okay? So the important thing to remember is that with a hospital, and this is a good thing for you to remember, the minute you start, sometimes they say ignorance is bliss, right? The less information you have, the less you need to react to it. Once you have that data, all right, once you start having a CLABSI or two, you sure as heck better be looking into why you're getting them. And if in fact why you're getting them can be directly traced to the product change, then in fact you need to respond to that. But as you know, there could be a myriad of factors in addition to the product change, which makes our whole industry, this is what makes it so complex and why if you don't work in a hospital, you really don't understand. But there could be a myriad of factors contributing to that infection rate. The important thing is that you start an investigation, you go to risk management, you conduct studies as to why this is happening. And if in fact the only reason that you can think of is the product change, then you better switch back or switch products.
Perfect, thank you.
Thank you, Russ.
Thanks. Thanks.